attended, you presented, Tim, and I remember you giving statistics on the different cancers and where you were getting specimens. And what was interesting is you had commented about the two orphan cancers, pancreatic and myeloma. And I think you actually had a lot more figures on those. And it wasn't that there were more of them, because obviously there's such a more of an orphan cancer. But you actually had information on them. And Kay and I turned to each other and said, I mean, there's actually information on this. Now, how do we connect, you know, the researchers to the people? I mean, they're coming in, they're getting diagnosed. So I think this is a really wonderful kind of issue for us to be looking at. I'm hearing, you know, Wendy, you're saying, well, I'm able to get that when I come out of my lab and come and talk to the people, okay? And I think that's a big part of it. And in an interesting way, because one of the thoughts I had when I first got involved with this, very naively, was, well, if we patients said, we want more, that this could start driving it. And I think in a way, it helps. But it's really, we're having to do this. We have to come from the top, we have to come from the bottom, and it has to be, you know, a concerted effort. Now, what you're seeing here, Tim, is the fact that researchers will come out and talk, and researchers really care. But the rest of the community rarely has this opportunity. But again, we're sitting here, even though I'm fairly ignorant, is that most of the people here, you know, can understand you. So coming and then talking to people kind of further and further down that chain will require different approaches.
I was just going to say, I felt like, you know, one of the pioneers coming out to the Wild West way back when, because several years ago I worked in an institution. We were the pioneering research bank out here, and we made tons of mistakes because it was like the blind leading the blind. Nobody knew what they were doing. And, you know, so it was up to the coordinators to figure this all out, you know, and to do the literature review or whatever. We didn't know how the surgeons were going to react and how the pathologists were going to react. And basically we heard from the surgeons, yeah, you can approach our patients, but then there were HIPAA laws, so we couldn't approach them until they were actually in the hospital, because we weren't a covered entity, you know, from a legal standpoint until the patient actually hit the institution. So we couldn't call them beforehand and talk to them. So, you know, we really learned a lot, but basically the physicians at the time were, you figure it out, and you know, you talk to my staff and you do what you need to do, you have my blessing. And so everywhere, like, okay, what do we do from here? And trying to explain that to the physicians, explain stuff to the patients. And the physicians were too busy, they didn't want to approach the patients, and their staff was too busy, they didn't want to approach the patients. I think in talking to colleagues at different hospitals now, they learned a lot from our mistakes, because they came to us initially and we said, this is what we did, here are the problems or whatever. If you want to make your procurement successful, here were the problems, and this is what you have to hit head on, and you have to get buy-in from these people, and these people. And you don't want to do what we did, because I know there are still problems, because people got into a groove and into a mindset early on, and changing that is really difficult. So, you know, I think you need to educate and get buy-in from everybody first before you go in. You shouldn't dive in head first. You need to make sure the infrastructure is there and then go forward. And so a lot of the, well, can't you just get it? There are a lot of pieces and parts.
And then our original question is, who are our target audience? So I envision physicians, I also envision hospital administrators, because like you say, it costs money. And there's all of those issues as well. The researchers, and you need to have, I think you need to have a mission, an institution with a mission that says research is of value and something that we value and support with real money. It's not a free process. And that's some of the politics that Tim's part of that. People ask for it, but they're willing to demand it. If it's a You have to play that with politics.
Yeah, that's a whole, we could spend many hours on politics. I think you wanted to comment.
I just wanted to comment a little bit on what Tim was saying, and that is, I think, I mean, researchers can get tissue, but it's usually through individual efforts. Like you have to, as a researcher, go out and find it somewhere in the world. I say that because we've done that. And you can get it, but I think the problem is the lack of like a central, you know, some kind of a central station where you go to get tissue for everybody, because it's usually just now, it's first come, first serve. You have to knock on a lot of doors before you find, especially if you don't work in a hospital setting like TGen, you have to have like close affiliation with Mayo, and then, for example, they'll have a really strong hold on the samples, and you know, you have to, so it's basically, there's a lot of give and take, you know, but if there was some kind of like central kind of, and there are these, like, I don't know, you must have all heard of CHDN, for example, right? But those are, they're not that effective, and a lot of people don't like to use them in my experience, because, you know, you'll call them and ask for, they collect all tumor types, and then you might get 3 or 4 or 5, you know, so if there was something that was centralized, where everybody just knew to go to, as opposed to having to sort of find the needle in the haystack sometimes. That would be.
Back on the East Coast, we did early detection markers for cancer, and we were part of something called Early Detection Research Network. And it is kind of like the old pathologist. Hopefully, I'm sure these are all grandfather things. These are people who have thousands of specimens stored away in there. Now, they haven't all been processed the same, which is one issue. But these are people who have just over the years just saved all of their specimens. They have limited information, they can now be identified. And you could get thousands and thousands of specimens for our research. And that network, and there are other ones like that, are worth considering. They are not all the same, that's one of the issues.
Oh yeah, no, I know.
But you can all get 1,000 from Dr. Smith, you can at least get 1,000 of his, and hopefully they can all collect the same.
Yeah, in Canada, I worked in a lab that collected brain tumors, and it was the same thing. We had thousands of brain tumor specimens, and so all the researchers in that network had tissue at their fingertips whenever they needed it. It was right there. And I think the Canadians, in my opinion, are ahead of the game on the tissue banking process. Because I think now it's pretty standard, at least on most of the major sites, like cities. Consenting for tissue is part of the surgical consent process. It's just another form that they throw in there, and every patient going through surgery will be asked, in addition to consenting for surgery, will you be willing to get any extra tissue for research?
And their whole medical system is much more the same because it's single payer.
Yeah.
So the whole country is more unified, and it's easier to do a clinical study there for that reason.
Yeah.
I know early on, where I started, originally there was a clause in the surgical consent that said that, you know, any remaining tissue would be left up to the discretion of the pathology department. And I know we went back and forth, and we decided in the end to consent patients separately for tissue donation because of the legal ramifications. But initially, we started with that, and the IRB came in and said, no, it's a person who's living, yada, 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 you know, we want a whole new consent process. So it started out that way. But I think one good thing about TGen, they're working collaboratively with a number of different hospitals. So there is starting to be some form of standardization and unity. And Deborah and I were talking earlier, and they said, you know, we were talking about computers and punch cards, and now we're talking about personalized medicine. And I said, you know, I remember using punch cards way back when, and we're kind of like that here now, where in 20 years, this will all be a moot point because it will be so well defined, and hopefully 20 years from now we will be having these same kind of conversations. But we're right now at the beginning stages, and everybody's making mistakes. But I see we are making progress.